Hello everyone, welcome to MedNews India, bringing you expert voices and the latest updates from the world of healthcare. I am your host Dushyant Magu, and today we are diving into a condition that touches the lives of thousands of families every year: blood cancers and disorders in children and adults. Joining me is a very special guest today, Dr. Gaurav Dixit, a leading hemato-oncologist from Paras Hospital, Gurugram. Today, he will walk us through understanding different blood disorders, the ins and outs of bone marrow transplants, donor challenges, and the latest innovations such as CAR T-cell therapy. Without further delay, let us begin our insightful discussion. Welcome, Dr. Dixit. It's a pleasure to have you with us today.
Thank you.
To start, I would like to ask, what is the real difference between leukemia, lymphoma, and myeloma? How do their treatment differ from each other?
Thank you, Mr. Dushyant, for this question. So first I will talk about the similarities. So all three are blood cancers. Now talking about differences, there is a lot of difference in terms of management, in terms of presentation, in terms of outcomes. So leukemias are more acute in presentation. It comes as a bolt off from the blue. Patients are symptomatic very acutely, and patients will say that they were playing football 2 weeks back and they have come now with fever, they have come with bleeding. So patients are more sick in case of leukemia. Lymphoma, it comes more slowly, and patients will say that I have long-term fever. From last 3 months, I am having weight loss. There may be some lymph nodes in the neck or in the groin region. So they are apparently they are more well-looking and they are chronically ill. So sometimes they are confused with tuberculosis, and many of them they are on tuberculosis medications also. So the third type of blood cancer is multiple myeloma, and multiple myeloma is mostly seen in elderly age group, more than 65 years to 70 years. Patients usually have anemia. Patients come with severe weakness. They will complain that they have fatigue and chest pain or difficulty in breathing. Another common symptom is back pain. So these are the common symptoms in multiple myeloma, and along with that, some patients have kidney issues also. So these are the main symptoms difference. Now, treatment-wise, leukemia requires more aggressive therapy. In lymphoma, treatment is slightly more acceptable to patients. It is less intense, and in multiple myeloma it is even less intense. Bone marrow transplant is required in most of the patients in AML. Talking about lymphoma, chemotherapy is sufficient. Patients don't require transplant in most of the cases, but in case they relapse, bone marrow transplant is required. In multiple myeloma, in patients who are fit, who are reasonably young, we offer them bone marrow transplant because it helps in prolonging the survival, and it helps in reducing the chemotherapy duration. So this is the broad difference between three types of blood cancers.
How exactly a bone marrow transplant works, and when do you decide it is the only option?
Bone marrow transplant is if I would say, in North India, you must have heard about Parali situation, in which bad crop is there, it is burnt, and when the next season comes, they put some seeds. So there is something like that, and bone marrow transplant is a medical procedure in which we eradicate the diseased bone marrow and replace it by a healthy bone marrow. And there are many indications of doing it. There are many types of doing it. Like in some cases, we use autologous stem cells, in which patients' own stem cells are required. In some cases, allogeneic stem cells are used, in which we use stem cells from the donor. And depending upon the type of disease, a type of transplant is offered. Like in leukemias and in benign disease like sickle cell disease, we offer them allogeneic transplant. And in patients of multiple myeloma and lymphoma, we offer them autologous transplant. So after wiping off bone marrow, we put new bone marrow and which makes new blood system. So this is how it works. First step is eradication of disease. Second step is putting new cells in the bone marrow, and third step is when the bone marrow grows to a new blood system. That is how disease is eradicated.
How do you decide between autologous and allogenic transplant? What is the risk in each case?
So autologous transplant uses a patient's own stem cell, and allogeneic transplant, as we have discussed, requires a donor. Allogeneic transplant as a whole is slightly more riskier as compared to autologous transplant. Main problems in transplant is infection, rejection, and GVHD, which is more in patients of allogeneic transplant. In autologous transplant, there is no risk of rejection or GVHD because patient's own stem cells are used and acceptance is very good. Only risk in autologous transplant is infection, and if we keep patients in a sterile environment, we give them a good care. If the team is experienced, the chance of infections and severe complications are very, very less in autologous transplant. Now in allogenic transplant, if there is full match, again the complications are less, but still they are not zero. And we tell patients that infections, rejections, and GVHD are the main issues post full match. And if patients have half match, although there are many techniques now to reduce the risk of complications now, but still they are slightly more than the full match transplant. So these are the broad types and complications of two procedures. Yeah.
So doctor, who can be a donor for bone marrow transplant? Can a parent donate to their child?
So in full match donor, ideal donor is in allogeneic transplant, the full match donor is the ideal donor. A full match donor is usually the sibling, brother or sister. But problem is that all patients, they don't have full match donor. So in that cases, we offer them half match transplant if required. Half match transplants, most of the patients, they have half match transplant in their families. So parents are always half matched. A sibling can be half match. So it's very easy to find a half match donor. But preference is always given to full match donor, because if we have a full match donor, then patient's body will take those cells as their own cells, and chance of rejection and other complications like graft versus host disease, in which donor's cell fights against a patient's body cells, they are very less if there is full match. So these are the two types of matches that we do transplant. Third type of match is mud transplant, in which we look out for donors in the registries, and there are various databases from which donors are found, and if patients are lucky, then they have a good match donor from registry also.
What is HLA matching, and why do so many patients struggle to find a perfect donor?
So HLA antigens are the proteins which are found on blood cells of everybody, including all of us, and these are the proteins which determine to a large extent whether whether body will accept donor cells or body will not accept donor cells. HLA typing is very important in all kinds of transplant, and so if there is full match transplant, patient's body will think that these are his own cells, and as we have discussed, the chance of complications and reactions are very less. So this is the benefit of having full match, but the main problem is that the chance of finding full match is very less in the family. And suppose I have one brother, so chance of having my brother having full match with me is only 25%. So most of the patients nowadays, we know that we have single child families, and single child families, they don't have siblings. So it becomes a challenge to find out a good match in those cases. And in those cases, it is feasible to take parents as donor, or a sibling who is not full match, and especially in patients of leukemia or patients who have difficult to treat diseases, it's a kind of feasible option with the protocols that we use nowadays.
So, doctor, is it true that most Indians don't register as donors because of myths or fears?
Yes, absolutely. And as far as I know, Indian registry has only about 50 to 60,000 donors, whereas registries in West like DKMS, which is a German registry, or NMDP, which is American registry, they have lakhs and millions of donors. And we have personally conducted multiple drives in which responses, they have not been very good, because there are many myths which are involved with bone marrow transplant. The most important myth is most of the donors, they think that this is some kind of surgery or operation, and they equate this bone marrow transplant with kidney transplant or liver transplant. And in bone marrow transplant, it should be clear to everybody that it's just like a blood donation, and you are saving somebody's life with a simple blood donation. And there is no anesthesia, there is no surgery, there is no pre-operative, post-operative complications along with bone marrow transplant. Many a times we have seen that patients, we have heard about platelet donation, FFP donation. So this is just like that, and we are not taking any organ out of the donor. So this is a myth which is there in most of the patients' mind, people's mind, and that's why they don't register. And we have also seen that a few times just before the transplant, donors have refused, and patients have sued doctor because of this. So this is a challenge which we frequently face in India.
So, doctor, can you share a real story where a patient from abroad came to India for bone marrow transplant and was saved when all the hope was lost?
Yes, there are many stories, but one story which comes to my mind is Master T. I won't take the full name, from Kenya. And a patient was a case of ETP ALL, which is very difficult to treat leukemia, and it is prone to relapse. So patient came to us in a very poor condition, and he had relapsed disease. When we started chemo, I was not hopeful that he is going to make it, but we started very slowly, and we gave incremental doses of chemotherapy so that he can take it well. There were problems during the transplant phase. Patient had very bad mucositis, he had fever, but mother was very resilient. She was very determined to take child through that phase, and luckily we found a full match donor in her sister, and we were able to complete that transplant successfully. So that is one story which comes to my mind whenever I think of any challenging patient.
Can patients live a normal life post-transplant?
Post-transplant, talking about autologous transplant, more or less they come back to normal life in 1 month, and post 1 month we advise them to be cautious and avoid any gatherings, or avoid any contaminated food or any other. So they should avoid any kind of infections basically. But the rigidity of isolation is less, and they can carry on with their normal work after about a month or two. Talking about allogeneic transplant, it is a bit more a tricky situation, because patients are immunosuppressed for about 3 months to 1 year, depending upon the type of transplant that we have offered. And in full match, patients come back to normal very early, and in half match transplant, they require a longer follow-up up to 1 year or more. And during this phase, patients and caretakers should be aware of the possible complications, including infections, including graft versus host disease, and including the risk of rejection. And they should keep a constant follow-up with their doctors, so that all their effort is not wasted. And once they are, the most critical phase is first 3 months, and then comes the first year. And once patients cross their first year, first 1.5 years, chance of relapse is very minimal, and they can slowly turn back to their normal life.
Can you explain CAR T cell therapy, which we all have been hearing as the latest innovation?
CAR T cell therapy is a new therapy in India, and it was introduced only 1.5 years back. Although in West it's available for last many years, and it's kind of rearming your immune system, because sometimes when leukemia or cancer is prolonged, patient has received multiple chemotherapies, then body's immune cells, they become weak. They are not able to fight cancer properly. So in this case, the first step is we take out their immune cells, we rearm them. It means CARs are inserted, or they are given ammunition or pistols, whatever you say, and after that it is given back to the patient, and supposedly they go back inside and they fight cancer cells. So this is how CAR T cell works. In India now, it is available only for lymphoma and leukemia, and going forward there are many new indications which are coming up, including multiple myeloma and other autoimmune diseases. So the advantages are that it's a very safe therapy. It does not require any donor. Patient's own cells are used. It's relatively safe, and experience with Indian CAR T has shown that the risk of neurological complications and other problems are also manageable. So, and it can be offered to older age also, and in India also, in patients up to 80 years of age has been offered this therapy. So there are it's sometimes everything, when everything fails, CAR T is the only option to offer in case of relapsed and refractory leukemias and lymphomas.
Thank you so much, Dr. Dixit, for sharing your valuable insights and helping us understand these complex topics better. To all our viewers, if you are or your loved ones is dealing with blood disorder, know that you are not alone. There are experts and treatments available to help you on your journey. At MedSurge India, we are committed to connecting you with the top medical specialists and providing support every step of the way. Thank you for watching. If you found this information helpful, don't forget to like, share and subscribe to MedNews India. Stay informed, stay healthy, and we will see you next time.